راح نحكي الآن عن reactive erythemas, erythema multiforme, urticaria, and erythema nodosum. Reactive erythemas, primary skin lesion is elevated skin lesion, red in color, and it's not scaly. It's not scaly means that there's no epidermal involvement. كل الباثولوجي في الديرمس. الباثولوجي involves vasodilation and immune response. فلما نشوف reactive erythema next step انه نعمل ايش؟ diascopy. diascopy اللي هي pressure with a slide بيصير في عندي complete blanching للليجن. اذا ما كان في complete blanching معناته this redness is resulting from damage of the endothelial cells موجودة في blood vessels في الديرمس, which means vasculitis. If it's completely blanching معناته عندي reactive erythemas. differential erythema multiforme, urticaria, and erythema nodosum. ما عندي scale formation in those lesions, which means that there is no epidermal involvement. Pathology is mainly في الديرمس and at the dermo-epidermal junction and sometimes at the basal cell layer زي ما راح نشوف في erythema multiforme. بلش بالارتكاريا. الارتكاريا هي عبارة عن reactive condition mediated by mast cell release of histamine, which might result in dermal edema. فالباثولوجي في الويل اللي هي primary lesion في الارتكاريا is dermal edema. إذا كان الإديمة موجود في السبكتينيوس تيشو بيعمل لي angioedema. فالويل is elevated, evanescent, compressible skin black, itchy, resulting from mast cell degranulation. Inside the mast cell we have histamine and we have other mediators, leukotriene, prostaglandin, etc. A single lesion of urticaria stays on the skin less than 24 hours, which means if the lesion appears on the dorsum of the right hand of the patient with redness, it was not scaly, it was elevated with edema, it should stay on the skin at the same site less than 24 hours and then appears at different other sites. But a single lesion on the same site should not stay more than 24 hours. If so, then most likely it's not urticaria. It's not urticaria. Size usually less than 2 cm of the wheal, but sometimes they can be small or size according to the type of urticaria. Pathophysiology of urticaria at molecular level زي ما حكينا في عندي mast cell degranulation releasing histamine, which is usually found in granules inside the mast cell. Histamine will go to the blood vessels, causes vasodilation, transient endothelial dysfunction, and dermal edema. The cause of this degranulation can be due to complement activation, direct injury from chemicals or trauma or medications زي morphine, aspirin, ACE inhibitors, ARBs, أو immediate IgE hypersensitivity reaction نتيجة food allergy, drug allergy زي penicillin allergy, أو there are autoimmune bases for urticaria which is called chronic ordinary urticaria. Ordinary it comes on daily basis. If it comes less than twice a week بسموه occasional urticaria. فبالchronic autoimmune urticaria في عندي IgG antibody which works as antigen. It keeps stimulating the IgE receptors found on the mast cells and it causes chronic degranulation of the mast cell and chronic urticaria. Slide number 5 زي ما شايفين urticaria or mast cell which is involved in urticaria has many components, histamine, heparin, proteases and other inflammatory mediators. Let's go to slide number 7. زي ما حكينا the causes of the urticaria يمكن يكون indigenous, exogenous. Things that cause activation of the urticaria can be from inside the body or from outside the body. Something that activates the mast cell from inside the body could be infection, viral, bacterial, fungal, parasitic, hepatitis C, hepatitis B, infectious mononucleosis, H. pylori infection, mycoplasma, connective tissue disease, malignancies, hyperthyroidism, celiac disease, lymphoma, solid organ tumors. زي ما حكينا كل هالأشياء might cause urticaria because urticaria is a reactive condition to an underlying cause. مش شرط نشوف الكوز أو مش شرط يعني to find a cause for the urticaria, but those are well known to cause urticaria on the skin. Exogenous causes في عندي drugs زي non-steroidals, ACE inhibitors, ARBs, morphine, codeine, food and food additives. Sometimes food urticaria is well known to cause angioedema on the lips or urticaria at the site of contact with the skin. يمكن insect bite, يمكن pollens, يمكن animal dander, etc. The classification of urticaria according to the time. حكينا a single lesion stays on the skin less than 24 hours, but the duration of the disease as a whole can stay up to years. If the whole condition duration less than 6 weeks, this is called acute urticaria. There is no need to investigate thoroughly those patients. Try to dig deep in the history, look for the events that have surrounded the urticaria, like dental infection, neural infection, food ingestion, history of fever, new medication intake, history of travel, etc. Up to 1/3 of patients might be having urticaria due to drugs, the other 1/3 due to infections, foods, and 50% of patients there is no underlying cause for the acute urticaria. Treatment: high dose antihistamine. With chronic urticaria, it stays on the skin more than 6 weeks. A single lesion is than 24 hours, but the duration as a whole on the skin is more than 6 weeks. This chronic urticaria can be sometimes physical, autoimmune, pharmacological, hypersensitivity. Physical urticaria, there is underlying physical factor that causes an injury or a new antigen inside the skin which has activated the mast cells. It could be solar, cold, heat, cholinergic, dermographism, which is immediate pressure urticaria, and delayed pressure urticaria. For the physical urticaria زي ما حكينا في عندي physical factor that has triggered the mast cell to release its content. يمكن يكون cold urticaria. يعني patients report usually from the history that upon cold exposure they develop urticarial lesions. كيف نعمل confirmation بالعيادة؟ نجيب plastic bag نحط فيها ice, we put it on the thigh of the patient for about few minutes. Then the patient might develop urticarial lesion at the site of contact. ليش شو اللي صار؟ underlying pathogenesis انه صار في عندي مع cold exposure a new antigen that has activated the mast cell. We don't know what's that antigen, but this is the theory behind the physical urticaria. Physical injury to the skin produces a new antigen which results usually in mast cell degranulation. Cold urticaria has been associated with cryoglobulinemia, cryopyrogenemia, and cold agglutinin, which can be sometimes associated with lymphoproliferative diseases. Solar urticaria, upon sun exposure, within few minutes a patient might develop urticaria-like lesions. Heat urticaria, the same with heat exposure. Cholinergic urticaria, with excessive sweating resulting from anxiety, heat, or sexual excitement, the patient might develop activation of the cholinergic sympathetic fibers, which results in release of acetylcholine to activate the sweat glands. Upon activation of sweat glands and sweating, the patient might develop multiple follicular papules and macules. They are resembling viral xanthin, but they are urticaria in nature. They are not typical wheals as seen in other forms of urticaria, but because it's related to sweating, we see pinpoint macules and papules at follicular level. Again, they stay on the skin less than 24 hours. The other form of physical urticaria is called dermographism. Stroking of the skin or rubbing of the skin will produce urticaria in a linear form. This is called triple response of Lewis. If you scratch the skin, you will have red lines, and then axonal flare, and then wheal formation due to mast cell activation. Dermographism is the most common type of physical urticaria. Delayed pressure urticaria, it's a form of urticaria that appears after pressure for about 3 to 6 hours. It appears on the feet after walking, has after clapping, and buttocks after sitting. It's prostaglandin mediated rather than histamine, which means that the treatment is not antihistamine at this type. It's non-steroidals, anti-inflammatory medications. We said that non-steroidals usually induce chronic ordinary urticaria sometimes, or pharmacological urticaria. But in this case particularly, it's a treatment for the urticaria because simply the urticaria in delayed pressure type is mediated by prostaglandin, and the non-steroidals are inhibitor for the prostaglandin formation. Hypersensitivity, again, we said that the patient might be hypersensitive to an antigen. This antigen can get inside the body and activates mast cells through ingestion, inhalation, instillation, injection, insertion. So the typical example is penicillin hypersensitivity reaction. Sometimes food urticaria can be classified as hypersensitivity urticaria, like the patient is taking, it's allergic to soybeans or peanuts, peaches. If they get in direct contact with the skin, he might develop urticarial symptoms. Autoimmune urticaria, again, we've said the pathophysiology that we have T cells activate mast cells to produce IgG antibodies against the IgE receptors of the mast cell, which might lead to chronic degranulation. This type of urticaria has been associated with other autoimmune diseases like diabetes, pernicious anemia, and most importantly, abnormal thyroid function test. So the patient might have autoimmune thyroiditis. So one of the blood tests that can be requested in those patients is thyroid function test and anti-thyroperoxidase enzyme antibodies. Pharmacological urticaria, we said that some medications might induce urticaria directly through codeine, morphine, radiocontrast media, aspirin, non-steroidals. Contact urticaria, typical type is the food urticaria when it comes in contact with the mouth. Latex allergy, usually seen in latex gloves. If it comes in contact with the skin, the patient might develop urticaria at site of contact. Animal saliva, caterpillar, insect bite reaction, and some plants might cause contact urticaria directly when they come in contact with the skin and activates mast cell directly. Presentation of urticaria, as we've said, the primary lesion is wheal, stays in the skin less than 24 hours, and this appears without leaving any complications. The major symptoms, the patient might develop severe itching and burning sensation, especially at night. It can be associated with angioedema. In urticaria, the pathology is in the dermis. There's dermal edema, but in angioedema, it's deep in the subcutaneous tissue. So edema in the subcutaneous fatty tissue might lead to angioedema, mainly around the eyes, around the lips, and mucous membranes, in addition to the genital area. Look at this, slide 18. You'll see urticarial lesions on the left, and there's angioedema on the right. So the lesion is red, non-scaling. Next step, diascopy. Pressure with the slide. If it disappears completely blanching, this means that the redness has resulted from vasodilation rather than endothelial injury. And this redness will disappear in less than 24 hours in urticaria. If it stays more than 24 hours, then we are talking about erythema multiforme or insect bite reaction. The cause of urticaria depends on the cause. If the cause is known, then we try to avoid it. But in most cases, unfortunately, the cause is not known. If the urticaria is associated with angioedema, the activity of the condition can stay up to 5 years. But if it's appearing without urticaria, then within 6 months up to 1 year, there is spontaneous remission. There are no specific complications of urticaria except for the angioedema and anaphylaxis. Differential diagnosis, as we said, insect bite reaction usually appears just like urticaria. In the limbs, you might have single or group lesions together. It's just like urticaria, but it stays more than 24 hours. It's very itchy, and there is central punctum at the site of the sting in those lesions. Erythema multiforme appears as a target-like lesion. It's painful, itchy, with burning sensation at an acrofacial distribution. Acrofacial means acral skin, the distal part of the limbs, dorsum of the hand, dorsum of the feet. The other differential, forget about it. Investigations, in acute urticaria, there is no rule for any investigation at all. You need to go for the history, do physical examination, and then start treatment. In the history, try to concentrate or focus on the events that has surrounded the urticaria. Like if the patient has ingested recently any new medications, if he has a history of sore throat, dental infection, urine infection, history of fever, or history of travel. But there's no need for any further blood tests because most of the time they will be normal. This is an acute urticaria. If the patient reported that his urticaria is induced by one of the physical factors, or he has some sort of hypersensitivity urticaria to certain types of food, then we can do some bedside tests, like a break test. Break test, we want to induce urticarial lesion upon contact with the physical factor or chemical factor that has possibly triggered the urticaria. Like if the patient said that upon sun exposure, he developed severe urticarial lesion, we ask the patient to sit in the sun for a few minutes. If he developed urticaria, most likely, then he's having solar urticaria. Again, the same for the cold urticaria when we expose the skin of the patient to an ice pack. Those are bedside tests and might be helpful. Again, a prick test can be done for certain types of food. Like if peaches, if the patient is reporting that peaches, is causing his urticaria symptoms, we ask the patient to bring peaches to the clinic. We do prick test with a special needle to the peaches and then prick the skin of the patient. If he develops urticarial lesions within 10-15 minutes, because it's type 1 hypersensitivity reaction, we don't expect the reaction to appear after 48 hours like in patch testing. Then most likely he has some urticarial, some contact urticaria to the peaches, and we ask the patient to avoid this. But the blood tests are not necessary at all in the acute stage. In the chronic stage, we try to figure out if there is underlying condition like infections, malignancies, medications which has triggered the urticaria or an association or to be associated with urticaria. We start blood test by CBC differential ESR. CBC to look for any signs of malignancy, ESR again for any chronic infections or malignancies, connective tissue disease, ANA, ESR, thyroperoxidase enzyme antibodies, thyroid function test, hepatitis C and B profile, H. pylori antigen, because we've said that the urticaria at the chronic phase can be a reaction to underlying conditions. So those conditions need to be ruled out by specific investigations. RAS test is very unhelpful. It gives false negative and false positive results. So I'll try to do prick test for the things that the patient is suspecting to be a cause for his urticaria, rather than do the blood immunoassay for IgE level. Treatment for acute urticaria, jump directly to oral antihistamine non-sedating type. Nobody is using the sedating type because of the major side effects, which is sedation. There are two schools regarding the antihistamine use. Some people say we need to start by very high dose, 10 milligram loratadine 4 times a day, and then within 2 weeks, if there's good response regarding the number of lesions and activity of the condition, reduce the dose to 10 milligram twice. Or we can go with 10 milligram twice at the beginning for 2 weeks, good response, keep it the same dose, no response, increase the dose to up to 4 times a day. There is no rule for H2 blockers like famotidine or ranitidine at all. In 4 weeks, we assess the response. If there's good response, we keep the patient on the same treatment. No response, add montelukast and assess within 2 weeks. No response, add cyclosporin, because most of the urticaria can be immune-mediated on the chronic run. So cyclosporin will inhibit the function of T and B cells and reduce the amount of IgG, antibodies against the IgH receptors of the mast cells. No response, we can go to omalizumab, which is anti-IgE antibodies, has been approved for patients with chronic urticaria above the age of 16 and can be even used for bronchial asthma for patients who are above the 12. In the pregnancy, we can use sedating antihistamine and even non-sedating. Cetirizine, loratadine, and mesolastine are, hydroxyzine, cetirizine, and loratadine can be used safely in pregnancy, in addition to the sedating antihistamine. Sympathomimetic agent, they are not necessary at all for the urticaria, but can be used for patients with angioedema. The last slide, 28, summarize the major treatment options for the urticaria. Thank you.